Next, I would like to call upon Dr. Sujit Jagtap. So, he's a senior consultant pediatric and adult neurologist and epileptologist at Dinanath Mangeshkar Hospital. He's World Federation of Sleep certified consultant in sleep medicine. And I would like to add that he has one of the largest series of epilepsy surgery patients in India. So I think it's a treat to listen to him about epilepsy, and he'll be talking on status epilepticus.
So good evening all. At the outset, I will thank organizers and Comil for giving this opportunity. So today I'm going to speak how I approach the status epilepticus. Most of you see status, and once it is in the ICU, then your sleep goes. Because some are easy to treat, some are very difficult, and some are literally, you don't want them with you. So I will like to have some introduction, definitions, then pathophysiology, and I will have 8 to 9 cases. I want your active participation, and then treatment options. So what is status epilepticus? It is the second most common neurological emergency after the stroke, and it has higher morbidity as well as mortality, nearly 30% when it becomes super refractory. It is a manifestation of brain dysfunction rather than a distinct disease entity, and we should be more finding in the etiology is the most important thing when we treat status. So I will start with whom you will cause is in status. What is the duration? Whether it is 5 minutes, 30 minutes, 30 to 60 minutes, more than 60 minutes, or more than 24 hours. So what do you think? A, B, 1, 2, 3, 4. Option 2. Okay, very good. Anybody else? 5 minutes, okay. So previously it is like 30 minutes or 2 or more seizures continuously, but now that has been changed to 5 minutes. Why? Because the time is brain. As we say in the stroke, same thing happens in the status. More the time duration, there is more neuronal dysfunction, more neuronal injury. So that's why there is a rationale of bringing that 30 minutes time to the 5 minutes. 90% of the seizures last less than 2 minutes, maximum 1 minute. And this is with my personal observed experience in video age. So I see more and more generalized seizures also. So no, very few last more than 2 minutes. So that's why the 5 minutes is important, because if something is not stopping at 5 minutes, it is going to go on. And we have to act there very fast. So the operational definition, a time when the patient should be treated as having status epilepticus, even if not all such patients are in established status. So what is meaning of established status? So there are two things. We have T1 and T2. T1 is the time where dysfunction is going to happen, and T2 where there will be major dysfunction will happen. So when it is a motor manifestation, like generalized tonic-clonic we say, then the T1 is 5 minutes and 30 minutes. When it is focal aware seizure, previously used to call CPS or focal impaired awareness, it is 10 minutes and 60 minutes. And when it comes to absence status, I will show some examples also. It varies from 10 to 15 minutes, and we don't know what is the T2. So what is the most common cause of status you see in your practice? Whether it is related to low blood concentration of the anti-seizure medications, or remote symptomatic cause, stroke, hypoxia, or metabolic cause. What do you think? Answer 1 to 1. Okay. So you are correctly said it is answer 1. So most of the time it is due to low AD or anti-seizure medication concentration. Rest we can see, but most important thing is a non-compliance with the drugs that is there. Then we have metabolic causes secondary to stroke and other things. So what are the stages of status epilepticus? Stage 1 is a early or impending status, we call up to 5 minutes. Established status is 30 minutes to 60 minutes. Then when it 30 to 60 minutes, then stage is refractory. Anything lasts more than 60 minutes, we call it as a refractory status. And what is super refractory? Super refractory is more prolonged, so it is more than 24 hours when a status lasts, we call it as a super refractory status. So already I have covered this, so I will move on. So in super refractory, it recurs within 24 hours or does not patient improve. The exact incidence is unknown but is not uncommon, and nearly 15% of all patients admitted with status will have super refractory status epilepticus. So we should be more cautious and more aggressive in treating a status. So what is the pathophysiology? Why does they become super refractory or refractory? Because it is a dynamic state of the receptors on the axon surface. Previously we saw the neurons and axis there. So in status there is a receptor trafficking. So we have GABAergic neurons and we have GABAergic neurons, so which they get internalized, which are inhibitory, and because of which their number goes on reducing. More and more patient, as the time increases, does not respond to the benzodiazepines, and there is a upregulation of NMDA receptors, so which results more into the non-responsiveness to the treatment. So either there is a failure in inhibition, or there is an excess excitation of GABA or GABA unresponsiveness. So as I said, like acute stage, early on impending status, established status, refractory status, and malignant. And as the duration of status increases, mortality and morbidity increases. So what is the classification of status? Again, it can be convulsive status or non-convulsive. So what we call non-convulsive NCSC. So in convulsive, again, they can be a generalized tonic, clonic, myoclonic or absence. And similarly, in non-convulsive, we can have generalized or focal. So we should be more aware in detecting non-convulsive. So in which patient to suspect, we'll see further. So moving to the case 1, this was a 26-year lady who presented with fever, seizures and altered sensorium. She had a GTCS. On examination, she was confused, but there are no focal deficits. She did not have any meningeal signs. Because of fever, it was thought she was started on acyclovir and phenytoin. Her sensorium did not improve. Her bedside EEG showed there is diffuse slowing. So this is an encephalopathic EEG. As sir showed you about stages 1, 2, 3, 4 and awake record. This is diffuse. So it is like she is in deep sleep or deep coma, but she was drowsy. And day 2, she became obtunded. There is episodic eye deviation with facial twitching. She was started because of this on midazolam infusion, and EEG also supported this because EEG is showing there are delta waves, in addition there are spikes, and there is evolving rhythm if you look at the posterior cortex. So in the posterior there is evolving rhythm, so EEG is not good. Now EEG is evolving, so patient is definitely in status, though she is not in a clinical status, so it becomes more of a non-convulsive status then. And here you can see there is evolving rhythm, so she is having electrographic seizures. So in a status we have to decide, we have to manage the clinical seizures as well as the electrographic seizures also. Then there comes the pattern of burst suppression, what we want to achieve or not. So the midazolam was stepped up, then she was started on steroids. So because now she is not responding to the anesthetic midazolam, we started on immunomodulation. But EEG is not improving much, and EEG is showing periodic lateralized discharges. And now from day 3 to day 6 she was on midazolam. So still burst suppression was not achieved, so she was put on the thiapontan and EEG was not improving. So it shows burst suppression. So what is the role of burst suppression? It is thought to be that they reduce the seizures when we withdraw the drugs. Otherwise there is a dilemma whether burst suppression should be achieved in all patients or not. Now the thio was, because she did not have seizures, there was good burst suppression achieved for 48 hours. It was tried to taper and then she went into subtle status. So she had few movements and EEG again showed lateralized periodic discharges, nearly they were generalized. So now what? Day 9, we are become anxious. What you want to do? So here again you have to do recycling. So from we shifted her propofol, we shifted her to the ketamine. So in patients, especially who develops hypotension, we can use ketamine. And again, there is burst suppression was achieved. But EEG was not improving. It is showing lateralized discharges. And then again, there was a brief trial of propofol. Then we titrated topiramate. So rapid titration of topiramate is one of the drug which can use in status. Still seizures are going on. So what? Day 14 she had developed biplates. So she was added on verapamil and lacosamide. This is a case which we handled 15 years back. Now day 28 still she is not improving. She was received oral IV steroids, methylprednisolone. Still she is having electrographic seizures. Now, so what is our aim? And patient is not improving, no improvement in sensorium. So what to do? Should we stop or what should we do? So here comes the role of plasma exchange. So she underwent plasma exchange. You have to be patient and relatives also have to be patient. Otherwise both are going to lose. So by day 40, EEG showed improvement, no electrographic seizures, sensorium improved, discharge on day 50 without focal deficit. So this is the importance of you are being patient and patient relatives also being patient and cycling the drugs using the immunomodulatory therapy. Moving to case 2 which I treated 2 years back. This was 18 years boy. So he was 26, this is 18. Again there is history of fever. He had GTCS, admitted. He was on drowsy, started again on the similar cocktail what we do. After admission again he had a seizure. So his EEG was started, continuous monitoring. It showed, now you see there is a delta waves and there is a periodic discharges. So we know this is a ghastly EEG. So we have to act fast. So what happened? So EEG is not showing improvement. So he was started on midazolam infusion. 2 more seizures, midazolam was stepped up. Still drowsy, and then once you step up the midazolam, you require intubation and ventilation. Story continued. As then he was 24 hours seizure free. So it was tried to taper the midazolam, again had a seizure. So we started him on methylprednisolone. Lacosamide was added. Day 4 EEG, again as compared to the previous, there are epileptiform discharges, some lateralized discharges. But if you look on the right, on the red, this one, there you will see that there is a change in the discharges and there is a evolving rhythm, and now you see there is a electrographic seizure. So again this clinically no seizure, but EEG wise is showing electrographic seizures, and this started on the left side and then spread to the right side. So we have to monitor these patients with the EEG frequently or as far as possible continuous EEG. So what do you want to do? On day 5 is on midazolam infusion, methylprednisolone. Do you want to add 6 ASM? Do you want to add ketogenic diet, IVIG, plasma exchange, or as like previous patients we can't afford, so tell poor outcome, cannot do anything, take home. What do you want to do? Yes. So previous patient first we gave IVIG, here immunomodulation, first better to start early the plasma exchange. Because once you do the plasma, give IVIG, you can't do the plasma exchange. So act fast, do plasma exchange, and then you can give IVIG if it does not improve. So story continued, midazolam was stepped up, propofol was added, start ketogenic diet also early. Day 3 or day 4 you should think of ketogenic diet, that is important. Now we do atomic panel that came negative, MRI, no new changes. So we know what this is. This is either NORS or FIRES. I will tell what it is. Day 8, no seizures for 48 hours. EEG showed burst suppression on propofol and plex. Day 10 again had a brief seizure on the plasma exchange. We do alternate day cycling. So propofol tapered, topiramate added, sedated, parents anxious. Somebody told this boy will not survive. Why are you spending your money? They become more anxious. Again, day 10 EEG showing similar picture, periodic discharges are continuing. So, what you want to do? Again, after these so many days of ventilation, ICU stay, you develop fever, you develop UTI, you develop pneumonia. So, day 11, subtle seizures, day 13, 5 cycles are over. So, what you want to do now? Your all armamentum is over? No. Now he received IVIG. And with ketogenic diet, he was on continued. Day 16 becomes seizure free. Then there is slow taper of ketamine. Day 18 become conscious, tries to obey. And day 20 off ventilator. After day 30, he was discharged. Previously 50 days, this was 30 days. And this is the 3 months later, he is playing the piano. So without deficit. Such a bad story. Was asked to stop the treatment and go. So you should never lose the hope. So the super refractory term is making any sense? Yes, recovery of patient is not uncommon. Premature withdrawal of care should not be done merely because protracted treatment duration, and especially true in young patients and patients with normal MRI. So what these two cases we saw, they were NORS, that is new onset refractory status. So they can be fever induced, so what we call them are fires. They can be autoimmune or they can be cryptogenic. So we have three-pronged approach: termination of status, prevention of recurrence, and treatment of complications. So I have discussed all these things. To start with, we have ABC, give dextrose, give thiamine, then give benzodiazepines, lorazepam, midazolam or diazepam. Then you can give phenytoin, phenobarbital, fosphenytoin or levetiracetam, lacosamide as is first. Then add second, not settled in 60 minutes. You have to start midazolam. Not improving, add anesthetic agents. Early, you have to think of immunomodulation. So now, this boy who presented with prolonged episodes of confusion. If you look at the video, he is having eyelid myoclonia and perioral myoclonia. And he was previously well controlled on the drugs. So what happened? Why he became like this? Because somebody changed his sodium valproate to carbamazepine and he worsened. So this was a abstinence status he had, and this was his bad EEG during those episodes. And this is what we see: 3 years dart and dome appearance in habitual absence. Moving to this girl, 13 year, she presented with lower limb heaviness, initially infrequent seizures, then continuous jerking of the left leg and weakness. She received lacosamide and methylprednisolone. Look at her leg. It is continuous jerking, progressive developed weakness. And in addition, she started having daily multiple seizures where she had just abduction of both hands and she was not able to walk and stand. Her EEG corroborated to this. So there was right side, right hemispheric slowing and delta waves. And then there is a diffuse onset seizure. If you look at the MRI, it shows right hemispheric atrophy. In addition, there is hippocampal atrophy. So what is the diagnosis and how you want to manage her? She was on 5 drugs, she received methylprednisolone, received IVIG. So you want to give anesthesia now, midazolam infusion, you want to do surgery, plasma exchange or ketogenic diet. So here it is a refractory Rasmussen's encephalitis. Here the surgery, as it is non-dominant again, so surgery is the choice. She underwent right hemispherotomy, completely seizure-free and drug-free. This is the next case, 5-year boy who had seizures daily since last 1.5 months. Every 5 minutes he had global developmental delay. His MRI showed left hemimegalencephaly. He was referred us with the midazolam infusion. Look at the boy. This is a 5-year boy. He is very thin built. And look at his eyes, look at his hands. So he had a focal status. So there is an eye deviation to the right side. And look at his right hand. There is initially postured and then there will be clonic jerking. And his MRI shows there is a left hemimegalencephaly. So what you want to do? Now midazolam, you want to give IVIG, surgery, plasma exchange, ketogenic diet. So he is again a surgical candidate. He improved completely. Whenever there is structural abnormality, whether it is a focal cortical dysplasia, where it is a large glasses, hemispheric pathology, he should undergo surgery is early choice when they are status. We have published our paper about the epilepsy surgery in refractory status. So there were 10 patients, more common in the pediatric, but adult also we can do. So this is the routinely we can see in the ICU, fever and altered sensorium, and these chewing movements, this gentleman hand. So what do you want to do now? Which test will give a diagnosis? One simple test will give a diagnosis. What he is having? Why he is doing continuous chewing movements? Okay, I will show his EEG now. So EEG shows lateralized periodic discharges on the right side, left side. So in the red you can see, and the EEG became normal. This chewing stopped. You give one injection. So give lorazepam. So it is called, we call as benzodiazepine test, and it is considered positive if there is resolution of potential ictal EEG pattern or there is a clinical movement. So he was in the non-convulsive status. So what is when you consider a patient who had GTCS and a prolonged post-ictal period, or there is altered sensorium who demonstrates subtle signs such as twitching or blinking and or fluctuating mental status, patients in whom no other cause is available to explain the altered sensorium, then unexplained stupor in elderly, stroke patients who look clinically worse than expected. In them you should consider non-convulsive status. Here EEG is more important rather than clinical observation, as it determines the response to the treatment. Moving to the next case, this is 18-year girl, similar story, fever for 3-4 days, then behavioral change for 3 weeks, then she had a seizures, altered sensorium the 4th week. She received acyclovir, then midazolam infusion, methylprednisolone, and then she developed abnormal movements. She underwent tracheostomy, she was drowsy, she received IV also, but there was no improvement. So what are we dealing with? So this is NMDA encephalitis. So she underwent USG and CT which confirmed the ovarian teratoma. NMDA came positive, received IVIG and right salpingo-oophorectomy, and same moribund girl who was in the hospital for 1 month, within 1 week how she became. So this is one more case, 72-year female, presented initially with a giddiness, irrelevant talk and imbalance, started on one medication. In 2019 developed abnormal behavior, sweating with uprolling of eyes, salivation lasting for 5 to 10 minutes, once in 15 days, metabolic workup, in addition autoimmune workup negative, story continued. Now recurrent episodes of irrelevant talk, rolling on the ground, excessive sweating, unresponsiveness for 1 to 2 hours, daily 2 to 3 times, even in the sleep, so not functional. So what do you think? And this was when she had this episode, she was like this.
Adi, Adi.
Okay, I will take 1 more minute. So what is the diagnosis here? EEG showed there is diffuse slowing bifrontal delta and something. So what do you think? Is it autoimmune? Is it paraneoplastic, or whether it is non-convulsive? But she improved. One test, simple test. She improved, EEG became normal. So what do you think? What we gave? 25% dextrose. She turned out to have insulinoma. Okay, because of she had persistent hypoglycemia which manifested like non-convulsive status. So we have treatment options for super-refractory status, pharmacological and non-pharmacological. I discussed all the pharmacological. Similarly, we can have hypothermia, we can have emergency surgery, vagal nerve stimulation, transcranial stimulation, electroconvulsive therapy, and then we can have music therapy also. So this I have covered, this I have covered. In addition, now when it is a NORS, they don't respond. Another armamentarium what we have is a rituximab. If they don't respond to rituximab, we can give tocilizumab. And now I feel earlier the better, rather than rituximab, we should more, if it is a NORS not improving in 7 or 10 days, we should earlier think of tocilizumab in super refractory status epilepticus. Thank you.
Thank you, sir, for that elaborate talk. So many simulology videos and EEGs we discussed. So excellent talk, sir.